Thank you, Lisa. Okay, so let's take the next couple of minutes. In front of you or somewhere around you, there should be a piece of paper. We have more of these pieces of paper. We recognize that we will not be able to listen and hear all of y'all's ideas. Already I've gotten maybe 12 different ideas just from folks coming to me, so we're actively engaged in the process. I'd like to take a few minutes now to dialogue and just kind of ask you what are some of the more immediate hot button areas that you'd like to at least mention, and take the next couple of minutes to do that. So who would like to, they say your smile couldn't be any brighter. Lisa Jensen.
Thank you, Gil. For those of you who remember, just a moment ago I announced that I was the current board president of NAMI, and there's two events that I'd like to bring to the community's attention. The first is that our beloved Judge Spencer, we are hosting a thank you, God bless you, we love you, appreciate you luncheon July 11th. For those of you that have worked with her, you know that along with her partner in crime, Judge Hazen, they are the two most dedicated, committed people in our community. This luncheon is to thank her for that dedication, her years of service, and so if you have not responded to the NAMI invitation to purchase a ticket individually, please make contact with NAMI.org. The second thing is that I am a champion for NAMI because I am passionate about mental health. I also believe that knowledge is power. When you're informed and educated, then you can make treatment choices. NAMI offers so many different family-to-family basics, but we can't do that without the funding. Our funding for our walk, which is in October, is significantly lower than last year. I don't need to tell you, money's tight, donations are tight, resources are shrinking. So I implore you, I beg you to go to NAMI.org, take a look at our website, get a team. If you're a corporate business entity, take a look at whether you can give a sponsor and a donation. Our presenting with instructors, 12-week classes on NAMI basics, or family-to-family, or peer support, or connection, it saves lives. We keep people out of the hospital by providing the resources, and this is the one thing in our community that I think needs to be further developed, and we can't do that without everybody pulling together. So please make sure you contact NAMI.org to take a look at a walk or possibly a donation. Thank you, Gail.
So Lisa, since you have the microphone,
sure.
what do you think the consortium ought to focus on?
I have two thoughts about that, and thank you for putting me on the spot. The first thing is that I think we need to take a look at the amazing work that was done and do a gap analysis with the new 1115 projects that have come on board. In fact, in the book, there's a triangle that my partner in crime and I worked on in 2012, the pyramid. And that pyramid actually was color-coded for underserved areas in our community, and overserved, and complete gaps that didn't even exist in our community. I think we need to revisit that pyramid and redo an inventory. Beds are opening and closing, beds are changing, there's new hospitals out there that weren't there, and so I think we need to redo the pyramid and take a look at the gap analysis. The second thing that I think we need to do is that the Health Collaborative has already done an amazing work in getting community partners to focus on key mental health drivers. I think we need to get a presentation, putting you on the spot. I get a presentation from them to understand what they are. They've already got community partners in hospitals and businesses and other communities, and we need to be all aligned with those parameters. The third thing that I think needs to happen is that we've got to figure out a way to support NAMI. All across the country, NAMI is funded by commissioners, they're funded by mental health, they're funded by hospitals, and the reason they do that is so that they can have aftercare services and support, so they can have peer specialists to be going in and coaching, so that they can provide the education. And we've got to develop that. I personally believe that NAMI is one of the solutions to our mental health issues in San Antonio. Thanks for giving me the chance.
Gilbert, I just
Where do we focus on this?
I want to remind those of you who don't go to Polly's a banquet for NAMI, that I do have the ability to issue arrest warrants.
Okay, where do we focus on next as a collaborative?
I was just asking Judge Payson about this at the intermission. The little nonprofit that I work with now gets requests for help from social workers who are dealing with mentally ill families. And one of the requests we get pretty often is for help with minor children in the home. Typically, they will be babies.
Yeah.
Typically, it will be a crib, or it will be diapers, or it will be a gate at the top of the stairs because the kid's falling down the stairs, and the neighbors have reported the kid to Child Protective Services. In one instance, Child Protective Services wanted the 6-month-old baby to have a toy. We went out and bought him a couple of yellow rubber ducks for the bathtub. Cost us $2, I think. I think the cheapest we ever went was $1.50 hook and eye to hang on a screen door to keep the baby from running all over the parking lot. And the neighbor reported the baby to the Child Protective Services. When a mentally ill parent is threatened with custody, removal of custody, being taken to court, sometimes, most often, the baby will be removed, sometimes put in the custody of relatives, and sometimes just sent I don't quite know where. But when a sum, like the price of a crib or the price of a gate at the top of the stairs, what I would like to know is how does that compare with the cost of court of removing a child and putting a child in protective custody somewhere, paying somebody to take care of the kid, paying the defense lawyer, paying the judge, on and on and on and on. And why have no local governments, to my knowledge, undertaken the effort of trying to help mentally ill parents keep babies out of court when all it takes sometimes is such small sums? Thank you kindly.
What do we need to focus on? Where do we go?
Well, you all know we have a legislative session coming up, and I think that it's going to be very important that we all are on the same page and unified across our communities, so that when we go to the legislators, we're all speaking the same language. You heard equity of funding, and I hear a lot at the state level through an advisory panel that I'm on, looking at the public mental health system about efficiency, effectiveness, collaboration. Well, you know what? At the end of the day, you got to have some money. And I think we're all very creative. I think we're very collaborative. I think we try to make all the moving pieces fit together. But ultimately, I think it's going to take more money. And so I hope that and I know Gilbert will be leading a legislative symposium here very soon to start getting us on the same page so that NAMI knows what the agenda is coming out of their county. The Health Collaborative, all of us know what we're going to be asking for, so we have a unified voice. So to me, that's one of the top priorities right now.
Colonel, I'm getting to you.
He's got his gun, so if you don't like what I say, he's going to shoot. I'm the chairman by default of the San Antonio Coalition for Veterans and Families. I don't know much about what you guys do. I just know that what you do is very, very important, very, very needed. I wanted to say this to you. What happened to us, I think applies to what can happen to you, and we found some answers. When we first started our first meeting, we found that everyone had a silo mentality, a stovepipe mentality. With that came secrecy. I'm not going to let what we do share it with anybody else. And as a result of that, there was always competition. We had to make that change, a behavioral change. And that behavioral change brought collaboration. After we found out that we had a silo mentality, we're not about competition. What we do is what we do, but the focus is through collaboration and networking and trusting the system to work with you so that you can stay focused on one mission. And in this case, your mission is the mental health. Our mission is our veterans. And if we can focus on that, pretty soon we begin to say, you know what, it's working. And therefore, instead of being stingy or secretive, who loses? The patient. The family loses. You have got to make that change. And the sooner you make it, the better off it's going to be. I can't wait for Ms. Sanchez, who's 27 years old and will be here for a long time, that she will put in a budget, not for $1 million or $10 million, but why not $100 million for all of us so that we can make that happen. Will that happen next year? Absolutely not. But if we don't start thinking in that way, we're going to be duplicating all kinds of efforts. Marketing, purchasing, advertising, administration, you name it, and we can make that consolidation. We merged with Alliance for Veterans and Families because it made sense. So don't be afraid. You know, you got a job, you can always get another job. We don't want you to lose jobs. We want you to make improvements into what we're doing, and you can make it happen through this. I admire and applaud what you do. Keep it simple. In the military, we say, keep it simple, stupid. Because if not, we get too complicated. The other thing I may say to you, I'm 76. You guys talk, and I said, wow, what does that word mean? Wow, what does that mean? Tell me simple. Your patients are simple, not simple-minded, they're just the language that we have. And our veterans, 88% of our veterans are enlisted. Some of them have college, but you know, you gotta speak straight. So people understand, there's no misunderstanding. Thank you.
Where do we go from here?
Sergeant Garza with the Sheriff's Office. You know, the Sheriff spoke earlier about our use of force has gone down, and it's highly attributed to the CIT training that the Sheriff has made mandatory and the Chief of Police for SAPD has made mandatory. But let's take it a step further. Our numbers and our stats prove that this works. The training works in identifying persons that suffer from mental illness, how to address it, and what actions we can take to make that situation to come to a peaceful resolution and ultimately get the person the help that they need. So let's take it a step further and just make the legislation mandate that from now on, all officers entering any basic training or police academy in the state of Texas have to have a 40-hour CIT training course. Make it mandatory before you graduate. You have not just voluntary like the two agencies here in San Antonio are doing, but make it mandatory. And for those officers that have already been here, before you qualify to get an advanced license through TICO, make it that right now you have to take child investigations courses and whatnot. Let's add the mandatory 40-hour course before you can get your intermediate licenses and above.
So Lieutenant, SAPD, you agree with that, right?
I will say that for us, officers now, they are required to take CIT courses now because, as you can see, all of us are now carrying tasers. In order to carry a taser, we have to be put through a 40-hour course. And that's where I had the nice pleasure of meeting Gilbert a long time ago when we were offering those courses. So I will say that Sergeant's right on that. I'm glad to see that. Before it wasn't a required course, it was optional. And I started to see a lot of officers taking them now so they can handle the calls more in a calmly, peaceful way. Don't have to rush through the call, try to get everybody getting where they need to be. So yes, I concur with that. Thank you.
I think that the same way that we have a pyramid for the adults, we really need to focus on that delivery of care for the children in a comprehensive way, because definitely prevention, and all of us know that the earlier you intervene, the more possibilities you have for success. And I think we're not doing enough at all levels, focusing on our children and engaging the community and reducing the stigma. And so I think that all of us need to work together to bring those consumers, to bring the families to the table, and increase their education and work on the prevention. And in every, working with the schools. I mean, I don't think anybody from the schools are here, but I think that is a very important thing, because prevention, we do very little, and we spend a lot of money and a lot of time on intervening on cases that are very, very far along. And so I think that's an emphasis. And the other part, it will be the data, and I think we started the conversations about, compiling all that data that helps all of us to make a case for the need, and then also for the focus on the outcomes. Thank you.
Where do we go next?
Hey, Michael Zito with the Judicial Services with the county. I just wanted to kind of update you on some things that were happening, because I know, on page 24, I identified CMAG 24/7 assessments on individuals. The county's been very active in doing some studies. We contracted with Dr. Fabello, Tony Fabello, I don't know if you know him or not, but he's with the Council of State Governments, and they finished, prior to doing our study, New York City with Mayor Bloomberg back then had asked them to do a study on their system and how it impacted individuals with mental health issues. So the county contracted with Dr. Fabello to look at jail population, look at individuals that are arrested, and it was very interesting because he looked at over 70,000 cases and compared UHS information for mental health against that group that were out there. And basically what he found was that we weren't doing a very good job on identifying individuals. We were only capturing about 5% of those individuals, and 95% we didn't know. And those are the individuals that get released. They make surety bond, they'll get out on PR bond, and they don't show up for court. They're not, there are a lot of issues, and we're not making the connections with them. So their study, what I'm going to do is ask Gilbert, maybe if we can post it on the website once you have it out there, but Bexar County is now going to become a national demonstration site, and they're going to look at the mental health issues, and we're going to contract. Our second part now is the actual implementation part of it. So it's going to be Bexar County, and then also the Meadows Foundation. I don't know if you're familiar with Meadows, but they have put together the Meadows Institute for Mental Health, and they're going to specialize and work with Bexar County in doing gap analysis. And I think they may have contacted some of you before to address the gap analysis, but also work through the continuum issues and individuals that come into the system, identifying them, making sure we're plugging them into the right services so they're not coming back. And that's the main issue, because in the jail, 25% of the people that come to jail, that's the first time they've been there. 75% have been there before, okay? And we know who they are, but they come back. And so what Dr. Fabello is saying, we haven't done a good job with these individuals and their recycling. So if we can do better, that's how we can reduce jail population and make the community safer. So we'll continue to work there, and that's one of the things that I'd like to see us focus, is to continue that. And it's kind of on the criminal, I believe the intervention stuff, we're way at the beginning, is where we need to be, but we need to stop the bleeding on this other end and get those systems down so we can concentrate on other things. Okay, thank you.
Thank you, Mike. Where should we go?
Thank you. Michael and I, VP for Operations at Nick's Behavioral Health. I've been on board for about 3 weeks and have had a lot of opportunity to meet a lot of wonderful people. It's been a little overwhelming. In fact, Joanne has made sure that I've stayed extremely busy the last few weeks getting to know what's taking place here within the mental health arena. Coming from a place prior to Houston, Chicago, it's very pleasing, very powerful to see what you all are doing, the awareness, the collaboration that's taking place. But more importantly, what the gentleman back here was talking about keeping the patient at the center. We talk about patient centricity. And one of the things that I've noticed in my 34-year career in acute healthcare as well as now behavioral is the fact that we have a flawed patient navigation system. And that's one of the things that I truly believe is something that we need to work on, and this is part of it. When we talk about community, I use community as an adjective, not as a noun or a pronoun. It takes a community and a community of effort to make that happen. The use of simpler words. You know, when I come from the acute side, I talk about case management. It's completely different than when you talk about it on the behavioral health side. We just had this conversation the other day. We've got to find a better way of managing our patients throughout the entire system. On the front end, being proactive, but more so on the back end, looking at all the additional services that one might require. I.e., we learned in the VA there in Chicago that if we put a roof over someone's home, we could get them back to some normalcy. We could get them into the therapy. We could get them into the medication management programs. We created social enterprises through our homeless programs. And a big part of that is that. Volunteers of America, another great organization helping women that are coming out of the institutions, especially those with families, trying to get them re-established. So I think that what we've got going on here is very impactful, and I would say that we need to continue to push forward and not make assumptions that everyone knows what we're doing. We talked about a gap analysis earlier on. There is duplicity, but there's got to be a better way of being able to take these finite resources and put them back in towards supporting our community.
My timekeeper has already said we got to move on. One last comment for Helen, and then we'll move on.
There's two things. One is sharing of information. All of us here, where we sit pretty much administrative or whatever, you know, we can have a great plan, but at the front line, if the staff does not share information, then we're done. Working corrections, the jail, probation, SASH, civil side, criminal side, I can tell you that it is very difficult with offenders with mental illness to get the information. They're poor historians, they lack insight, sometimes it's substance abuse. We can go on and on, but at the end of the day, at the front door and at the gate, if it's the staff that does not know that there is some kind of statute, a health and safety code, that providers, at least community agencies, some, can share information, and they won't give it to us. It's a do-over, and it's tough. The other thing is workforce. Even if by the grace of God, Aurora, John, Gilbert could get us $1 trillion, we still have shortage on psychiatrists, we have shortage on clinicians. And I'm already going on 50 years old, and I've been here in this community close to 25 years doing this. And the deal is, we need fresh legs, and we need people with a commitment. And it's getting tougher to find them, much less those that are culturally sensitive, that are willing to do this kind of work. I'm talking about case management. That is what you need also. That's it.
Thank you so much. So, Aurora, we won't ask you for 50 trillion. How much is the 100 million?
Let me get my checkbook.